Well, welcome everyone to this evening's Viva webinar, Cementation of the Indirect Restorations Update 2022. I'm Jeff Lineberry, a full-time practicing dentist here in Mooresville, North Carolina. I've been practicing for over 20 years, and outside the office, I've been involved with education and teaching on a variety of different levels. I graduated from the University of North Carolina, Chapel Hill in 2000 and got involved with the Pankey Institute not long after I graduated dental school. And then in 2009, I actually got involved with Spear Education as a visiting faculty member and contributing author and one of their online moderators. And not long ago, I also came back to Pankey Institute as a visiting faculty there as well. I've also been involved with the American Academy of Cosmetic Dentistry, and I got my accreditation back in 2017. And I've recently been involved with their board of trustees for their charitable foundation, Give Back a Smile, where we actually help domestic survivors regain their lives by restoring their smiles. Anyway, I want to thank you all for being here this evening and taking time out of your busy schedules. I am very blessed to be here and share with you all this evening. I also want to thank GC America for allowing us to do this program tonight. Quick disclaimer, any of the pictures that you see, no spot editing or alterations in the presentations is here. And so at the very end, we're going to have a question and answer session there. So if any of you have questions, I'll try to answer those questions at the very end. And I'll also offer up my email for any questions that you may have about this evening's program or anything else I can help you with. So we'll just jump right in and look. If we look at these variety of restorations here, if we look up here in the upper left-hand corner, we see that we've got a partial coverage lithium disilicate restoration and a full coverage lithium disilicate restoration. And then down below that, we have a full coverage zirconia bridge. And then just to the right of that, we have a gold inlay and a full coverage gold crowns. And yes, I still do gold in my practice. And up above here, there's a combination of zirconia and lithium disilicate full coverage restorations. And so the question is that do we cement all these different restorations the same? And the answer to that would be no, we don't. And so the question really comes up is when it comes to cementation in your practice, how do you decide what to use? In other words, do you have a drawer like this that you kind of simply go in there and grab whatever's there, or your assistant grabs that and you use whatever you normally use? And so the question is what is your thought process, or what is it that you decide to use and do as far as cement when it comes to these variety of different restorations? Back in the old days, cementation was a lot more simpler. We had zinc oxide eugenol, we had zinc phosphate, and I'll date myself a little bit and say that I remember in my student dental clinics that we actually had zinc phosphate with chilled glass slabs. We also had some fancy carboxylate cements and even some glass ionomers. And it wasn't long after that we started adding in all these other fancy ones like resin reinforced or modified glass ionomers, and then resin cements were coming along as well. And then, of course, now we have this whole new class of self-etching, self-conditioning resin cements. And so changes are occurring rapidly in dentistry. I think we can all agree that dentistry is changing quite a bit. One of the big things that we see with dentistry is that, of course, our overall materials that we have in indirect restorations have changed drastically over the years. Like I said, I graduated 20 years ago, but yet in 20 years, the amount of materials and restorations that have come to market for us practicing dental professionals has changed drastically. And so it's changed rapidly. And also with these rapid changes in different materials, we've had to change the types of luting and bonding cements and agents that are available to us. So all these things have kind of created somewhat of a level of complexity. And so, in fact, when I looked at one of our local catalogs. If you look in here, if you ever take the time to just glance in some of these catalogs, that if your assistant does all that, take time to glance and look, because when I look at it, there's at least 10 pages, yes, 10 pages of different cements in this one catalog. So there's no reason why this process has become very confusing. And really, this process should be very straightforward. It doesn't need to be complex or perplexing, to say the least. And so, in fact, one of the things that was rung true to me over the years is that we can take a restoration that may cost $1,000 or more, or depending on where you're at in the world, it is expensive for our patients. But yet, something that may just cost a few dollars can determine whether or not that restoration succeeds. And so one thing I want to kind of help clarify is that sometimes the terminology that we hear can also vary quite a bit. And so luting, by definition, is nothing more than sealing a joint. In other words, there's nothing really chemical in nature. It just basically fills in the gap between point A and point B. Cementing, on the other hand, is that we're putting a cement on a surface to stick things together with the cement. And of course, cementation is the art and process of cementing. So that's kind of what we're going to be talking about, is more about cementing. And of course, we can't leave out bonding. Bonding is adhesive dentistry that deals with adhesion and bonding of the materials to natural tooth structure. And a lot of the resin cements that we're going to be talking about falls in this category of bonding and adhesive dentistry. So our learning objectives this evening is simply we want to talk about the different types of cements that are available for the different types of materials that are concurrently used in proper conditioning of tooth and material. Understand that these concepts and blending these certain different types of indirect materials and cementation techniques to get a successful outcome when we're applying these clinically. So when it all comes down to this, where do we start when it comes to cementation? Well, first and foremost, like so many things in dentistry, we have to begin with the end in mind. We don't want to just simply go to that drawer and grab out some zinc oxide eugenol cement or some carboxylate cement, or we don't want to use a permanent cement for a temporary, and we don't want to use a temporary cement for a permanent restoration. So we have to think about what is it that we're doing and what is the long-term goal for the case. We also have to consider multiple factors. In other words, we have to think about several different things when it comes to creating an ideal outcome for our patients, but we also want our clinical dentistry to be successful in the end. So when it comes to that, before we get into materials, let's talk about the basics. And for some of you, like myself, it's been over 20 years, but a lot of these things we kind of talked about way back when in dental school, but it starts to play into what we do today. And one of the things that we have to think about when we're trying to determine whether we're going to bond a restoration or whether we're going to cement a restoration is the overall retention and resistance form of the tooth preparation itself. So let's talk about what is an ideal retention and resistance form. So retention is really determined by the axial wall height and the overall taper. And then ideally in the anterior teeth and premolar region, we need at least a 3 millimeter axial wall height. And we also need 4 millimeters of axial wall height in molars. But we need to combine that with at least a taper of 12 degrees or less. And that's when we kind of combine the buccal and lingual aspect of the tooth. And so when we look at things, this plays into the overall resistance of it. In other words, resistance by definition is that it's a reference to how easily that restoration can become displaced. And as we start to decrease the axial wall height and we start to increase the overall taper, then what we're going to start to see is that the overall resistance form of that. Finally, this is where resin cements can actually help in situations like this through adhesive dentistry. So here's a diagram. If we look at basically a regular crown preparation to the left with a full coverage restoration, what we'll see is that if it has an ideal 3 to 4 millimeter height of axial wall height and an ideal axial wall angulation, then what we're going to see is that the resistance and retention form is ideal. But then as we start to shorten the overall ideal axial wall heights, we see that restoration can be easier to displace. And same thing when we start to look at the overall taper, we can have an ideal overall axial wall height. But if we start to taper that drastically, then we can see why that restoration can be easier to be displaced. And so hence the reason why retention and resistance is one of the things that we have to actually consider when we're starting to decide about cementation versus bonding. So the other thing that we have to consider when it comes to bonding versus cementation is isolation. And isolation is critical for all things that we can do in dentistry, and some things are more so than others. And so when it comes to our restoration or indirect restorations, we have to consider, is the final margin placements going to be subgingival or supragingival? And so in cases where we have recurrent decay down below an existing restoration and it goes way subgingival or down on the cementum, we have to consider how well we can manage and isolate that. We have to also think about the overall tooth location. In other words, is it in the anterior versus the posterior? Because I can tell you it's a whole lot easier for me to manage a anterior tooth to isolate it versus a posterior tooth. So we also have to consider these wonderful things called patient management. I don't know about you all, but in my practice, I do have patients that are somewhat challenging at times, including they have gag reflexes, hypersalivation. They have issues with being somewhat difficult, if you will, during appointments. And so we have to consider sometimes those patients may be less than ideal as far as creating an isolation that's ideal for bonding. Tissue management is critical for whatever type of cement. We want to have the tissue properly managed where it's healthy. So that's critical for all things. And of course, the other thing is that can you use different types of isolation? Are you going to have to use cotton rolls, a dry angle? Can you use a rubber dam or an isodry? Can you use a variety of different methods to create an ideal isolation? We also have to think about the overall operator abilities and technique sensitivity. Now, you know, when it comes down to operator abilities and technique sensitivity, when it comes to what I can do now versus when I graduated out of dental school, there are two different things, and I manage things differently than I did 20 plus years ago. Resin cements, by definition, are usually more technique sensitive than, say, resin modified glass ionomers. And thus, operators have to execute the series of steps properly to get an ideal outcome with those types of cements. And of course, experience. Sometimes it's also about the different types of cements. If you have a new cement sitting in your drawer and you grab it out and you've never used it and you haven't reviewed the different steps of it, then sometimes that can also have a negative outcome on the overall technique that's being used. We have to think about the material requirements. In other words, the particular material that we're actually using. So back in the day, metal and metal ceramics, well, we didn't really have to bond anything for adequate strength. We had to have a certain thickness when it came to metal and metal ceramics. And a lot of times those were luted or cemented in place. But then as we've added in these different materials, then we have to start considering it, because different materials require different thicknesses in order to have adequate strength. And so feldspathic porcelain, for instance, it requires bonding for us to achieve a clinical outcome. We also have to think about lithium disilicate and zirconia. It can actually be cemented with adequate thickness, and we'll talk a little bit more about that in just a minute. And finally, lithium disilicate zirconia can also be just bonded to help overall clinical performance. So when it comes to bonding for material strength, we have to think about feldspathic. Feldspathic has been around for a long time, and it's kind of a lost art nowadays, and it's not used as much as it used to be when I graduated dental school 20 plus years ago. But when it's actually laminated or bonded to tooth structure, it can be very durable, but it has to be bonded in place for it to be successful. Now, when it comes to lithium disilicate, minimally, we need to have a minimum of 1 millimeter thickness. And of course, at that thickness, it has to be bonded. Ideally, in those situations, we really need 1.5 millimeters to 2 millimeters thickness for the overall material strength. And in those cases, you can actually cement those. And zirconia is obviously the hot material that's on the market nowadays. And what I've read from a variety of different dental laboratories, this is probably by far the largest segment that's growing in dentistry. And we'll talk more about zirconia and the different types of cements and bonding that you can do with it. But bottom line, the original zirconia, when it first came out, Bruxer, which was one of the original zirconias that came out, that was very opacious, strong, but it was not very aesthetic. These type of restorations were basically a 3-mole yttria content. And so what we found is that as the manufacturers have added higher yttria content, they become more translucent and more aesthetic restorations, which is awesome. The downside to it is that as they start to increase the overall yttria content, then we start to see a decrease in the overall strength. And so that's one thing that you have to think about when it comes to these different types of zirconia, is not all zirconia are the same. And so when it comes to the newer, more aesthetic zirconias, then we actually need a minimum of 1.2 millimeters thickness of restorative material for them to be cemented properly. And then we also have to think about color management. Bottom line, we have to think about in aesthetic areas, are we going to have an issue with the cements shining through? In other words, if you have a thinner restoration, then we have to think about, will that show through? And obviously this becomes a lot more concerning in aesthetic areas. And so that's another thing that we have to consider when it comes to bonding versus cementation. We also have to think about functional habits. When it comes to functional habits, I don't know about you all, but in my practice, I see a lot of patients that have a lot of wear and tear, excuse me, on their natural dentition. So this is also going to occur on our direct and indirect restorations. In other words, as I always tell patients, whatever you've destroyed from Mother Nature, you can destroy from something that's being man-made. So bonding versus cementing, sometimes when we bond restorations in place, the beauty of this is that this allows us to help overall retention and resistance to these restorations being displaced. Sometimes we hear and see these patients that come in that are clinchers and grinders and have parafunctional habits, and they knock our restorations loose and they come in. And of course, we can bond these restorations in place to help increase the overall retention and resistance. But one of the downsides to it is that we have to understand that whenever these forces are generated from the clenching and grinding, then that is going to get transmitted somewhere else. And that point of failure usually occurs at the weakest link, whether that's the restoration, whether that's the bond to the tooth or the root or somewhere. So we have to consider that. And bottom line, in functional habit patients that have parafunctional habits, we have to manage the clenching and grinding and the parafunctional habits. The other thing we have to think about is fluoride release and marginal protection. Not all cements and bonding materials have fluoride release and marginal protection. Indirect restorations do fail over time. It's a news alert if you haven't heard already. I've been doing dentistry for over 20 years, and I'm now coming to a part in my career where I have started to see some of my restorations fail. And so one of the common things that we see sometimes is that we see caries at the restorative tooth interface. And so fluoride release and marginal protection becomes important in these situations. Now, we have to consider patients that have higher decay rates. In other words, if they came in to your practice with a lot of decay, poor diet, they have xerostomia. One of the things that's really common nowadays, and I see it every day in my practice, is drug-induced xerostomia, where these patients come in and they are taking medications for high blood pressure and different types of anxiety, so on and so forth. All these different medications increase xerostomia, or dryness of the mouth. And so as that occurs, then we start to see decay rates go up. And in fact, a recent study shows that by simply adding one medication, if you take a patient of yours that is in your practice today, and they come in tomorrow and they start taking a blood pressure medication, then chances are of decay go up by as much as 40%. Yes, 40%. So it's a real thing that we're starting to see, especially with all the medications. This is one place that we'll talk a little bit more about is that resin modified glass ionomers can really start to shine because they do release fluorides. And this has, of course, helped reduce the secondary marginal decay. And of course, one thing that as you get further into your career, you also have to think about future retrievability. As we start taking restorations and we bond them in place, it's wonderful until you have to take them off. And I don't know about if any of you have already done that, but one thing that I have done over the years is that I've had to retrieve either zirconia restorations or full coverage lithium disilicate restorations that are bonded to the tooth, and that can be very challenging to do. And of course, nowadays there are lasers and so on and so forth that you can do to help remove that, but ultimately they can be very challenging to remove. So let's talk a little bit about workflow when it comes to cementation and bonding. So first and foremost, we got to know our material. We've got to know our materials for cementation and the bonding protocols and how to use them properly. We've got to know that. We also have to know the material for our indirect restoration and how do we properly pre-treat that restoration in order to place it properly. And of course, we have to know about what do we do to the tooth. In other words, what are proper tooth pre-treatments to create a successful environment for our indirect material and cement to work properly. So we'll talk a little bit about the materials. We'll talk about the cementation and the different types of cementation categories. Of course, these are popular ones that are out there. Resin modified glass ionomers. They've been around for a while. One of the popular things with them is that the nice thing is that they don't require a bonding agent. So we don't have to do any special pre-treatment of the tooth. And of course, ideally, this is where we want to use it when there's adequate retention and resistance for them. And ultimately, we don't want to have a situation where bonding is not required of the final restoration. Glass ionomers, of course, by history, they work by an ionic bond to the calcium in the tooth versus developing a hybrid layer, which is created during bonding. It's not as strong, but there is some bond to the tooth structure. One of the beauties of this material is that studies show that when we start putting these type of restorations in and we have an isolation concern, is that studies show that if that patient, for instance, swallows right before you put that restoration in, I know that you all never have that happen in your practice, but by them simply getting a little saliva on that tooth before putting it in, glass ionomers, resin modified glass ionomers, are not adversely affected by that. However, if we've got a resin bonding then this can actually decrease the overall bond strength up to 50%. And of course, resin modified glass ionomers do tolerate moisture better in subgingival margin locations. So in those areas where it's difficult to isolate, you're far down on the root surface, you're prepping into the furcation area, all these areas, it creates a more ideal area for using resin modified glass ionomers. And of course, the other thing is that I think about crown margins that are susceptible to decay and demineralization. In those patients that are high decay rate, then resin modified glass ionomers can be really helpful due to their fluoride release. And of course, there's good studies showing that this helps prevent the overall demineralization around the margins and the surrounding tooth structure. The other beauty of this material is that it is opaque white, which is really nice when it comes to cleaning up because it's easy to see. So it's easy to clean up, and the overall strength is decent. And like I said, the working time and setting time varies from different resin modified glass ionomer cements, but it's usually ideal from that standpoint. The variety of different resin modified glass ionomer cements that we see on the market today, these are different ones from different companies. I'll run through this real quick. Relax Luting Plus, cement from 3M. We have Nexus for resin modified glass ionomer from Kerr. We have Fuji Sim 2 resin modified glass ionomer from GC America. And of course, we got Fuji Sim Evolve by GC America. And then we got Miron Plus QM resin modified glass ionomer from Voco. So these are just some of the major ones out on the market today. So when it comes to resin modified glass ionomers, one of the evolutions that is occurring in resin modified glass ionomers is a trend toward easier. When I first started using resin modified glass ionomers, then it was mostly the only thing available was liquid and powder mixing. And then we started adding in paste and paste mixing. And now we're starting to have auto mixing and light curing options to help clean up. And so, in fact, GC America, this is a common thing that they've done along with a lot of the other manufacturers. They started with their GC Fuji Sim way back in 2001, right after I graduated. And then they added in their Fuji Sim Auto Mix. And then they came up with their Fuji Sim 2. And then they developed a now handy little Fuji Sim Evolve, where it's in a self-contained container of 2 different pastes. And we're seeing this across the board with a variety of different resin modified glass ionomers. And in this case, this particular material, the nice thing is that you can actually either use the auto mix mode, where you can use the tips and actually inject it directly into the restoration, or you can do a hand mix mode. So it's really nice from that standpoint. Some of the manufacturers don't allow that, but this particular one does. This is some geeky stuff, and I'll throw some of this stuff in for those of you that love looking at different bond strengths to different materials and tooth structure. But this is just showing the variety of different the major manufacturers that I mentioned earlier. This is a study showing the different ones here from Fuji Sim Evolve, and showing the Relax Luting Plus over here on the far side. And then we got Miron and Nexus in between. And this is just showing how well this stuff actually sticks to zirconia as well. And so, as you can see, you got upwards of 15 to 20 megapascals, which is when we compare that to way back when I used to use zinc phosphide, that's 2 to 3 times as much. This Fuji Sim Evolve is really easy. If we look over here in the lower right area, it's a matter of preparing the restoration. Then we clean and inject the resin modified glass ionomer into the restoration, and then we seed it, and then we easily kind of clean it up. So it's relatively easy and straightforward. The next class we're going to talk about, self-etch and self-priming. This is by and far probably one of the most highest, I guess, hottest ones that are out there on the market today. Self-adhesive, self-priming resin cements. Their claim to fame is that they're easy to use and clean up. They have better bond strength than just your conventional resin modified glass ionomers or any of the other types of cements that are not resin based. They're less technique sensitive than adhesive resin cements, and we're going to talk about adhesive resin cements here shortly. And then, of course, they're more aesthetic. In other words, in those aesthetic areas, if you're cementing a full coverage restoration on an anterior tooth, then you actually have some colors available, whether it's translucent or A2. It's not just an opacious white color. And of course, there's no bonding agent required because these materials have a self-adhesive, self-priming material in the resin cement that allows it to adhesively stick to the tooth. And then finally, the working time for these can be varied. And of course, we can always use light curing to tack it in place and kind of clean it up. As I said, this is the hot area. And of course, this is probably one of the areas where we have the most amount of players nowadays, is because this is where many of us are living nowadays with a lot of the all porcelain restorations. So these are some of the common ones on the market today. We have GC1 by GC America, Reliax, Unisim, Unisim 2. You'll see SmartSim 2, PermaSim 2.0, Bifex, Ivoclar, Multilink by Ivoclar, Panavia SC from Cure. So there's a wide variety of different self-adhesive resin cements. And one of the things I'll point out is that just like with the Reliax Unisim and the PermaSim 2 and the SmartSim 2, a lot of these are adding version 2, if you will, because they're constantly improving this classification of resin cements. And so we'll talk about that as well here shortly. And of course, the last one we're going to be talking about is the adhesive resin cements. And these are the ones that's been around for a while. These historically are the ones that have the best bonded tooth structure and material, and they have the best overall retention, historically speaking. But they're much more technique sensitive, and they do require a bonding protocol. And so, of course, these are the ones they don't tolerate moisture well at all. And so, obviously, isolation is critical for success for this type of bonding procedure, as it is for all bonding procedures. Of course, it can be difficult to clean up. And of course, some of these are light cured only, some are dual cured, and we'll talk about that. Light cured, of course, the beauty of these type of cements, when they're light cured, they give us maximum place control with placement. In other words, you can place multiple restorations because as long as there's no light that's shining on these, they won't set up. You can get a variety of different ones as far as the overall viscosity. Bond strength is excellent for these. And of course, ideally, we want to use these in restorations where the light can pass through easily, and we want cement color stability. Now, I will say that cement color stability was a concern or issue in the past, but now a lot of the newer dual cured resin cements have color stabilizers in it, so we don't see as much shifting and changes when it comes to overall cement color stability. The dual cured resin cements, which is a variety or the majority of the ones that we see, they can be used with limited light access or with restorations that don't allow light access. And of course, as I mentioned, the long-term color stability of the newer generation of these adhesive resin cements have pretty much kind of been overcome and managed through the manufacturers. These are the major players in adhesive resin cements nowadays. We have Panavia V5 from Cure, Panavia F2.0. We got Reliax Ultimate. We have Multilink Automix, VariLink 2, Choice 2, Calibra from Dense Black Caulk. And of course, we've got GCM Link Force from GC America. And here again, we'll show a little bit about the different types of strengths. And so this is the tensile bond strength to zirconia. We see that when we compare this to the resin modified glass ionomers, which were around 15 to 20, we're now up in the range of 40 megapascals when we start looking at some of these different types of cements for like the GCM Link Force and the Reliax Ultimate and the Multilink. So we get an excellent adhesive adhesion to zirconia. And of course, same thing. You know, one of the things that comes up, and we'll talk a little bit about here shortly is that some people say, well, you can't bond to zirconia, but you can. And so we can see that this material nowadays is bonding very well to zirconia, and if it's equivalent to porcelain here, because we're seeing very similar overall bond strengths to these different types of porcelains. When we look at the overall tensile bond strength to dentin, obviously that's less than it is to the actual porcelain itself, but we're still seeing upwards of anywhere from 12, 14, 18, 20 megapascals for the variety of different types of resin cements that we see here from these different manufacturers. And of course, we see that some of these are more adversely affected through these different cyclings. This is showing where these are thermal cyclings 20,000 times, so simulating years of service in the mouth. So ideally, when it kind of comes down to this, what we see is that basically technique sensitivity, as we go from resin modified glass ionomers to these self-etching conditioning resin cements and adhesive resin cements, as we go from left to right, the overall technique sensitivity goes up significantly. And we also see that as we go from the overall bond strength from the adhesive resin cements to the resin modified glass ionomers, we're starting to see that the overall bond strength is less as we go from the adhesive resin cements. So the question nowadays is, why not create the best of both worlds? Why not create a universal cement system? And this is where some of these different manufacturers, GC is one of them, they came out with their GC1, which is their self-adhesive resin cement. And we see that when we look over here to this far left side here, there again, this is some testing that was done showing that we get upwards of over 20 megapascals bonding to dentin. And then we see that as this goes through the cycling, it's fairly stable. Some of these other ones, as we see, we start to see a change of the overall bond strength. Well, what's interesting is that the bond cycling or bond to the overall zirconia and lithium disilicate, we have excellent bond strength to zirconia and lithium disilicate when we start comparing these different types of primers and materials that we're putting in here. So what's really interesting when it comes to this is that these materials are now starting to add different types of adhesive enhancing primers. In fact, what we're seeing is that these are essentially self-etching resin cements that they are now kind of adding, if you will, their secret sauce in an extra bottle in the system. So we can take a self-adhesive resin cement and use it just as it is, or if we need to add extra oomph to the bond, to the tooth, and to the restoration, then we have the secret sauce, if you will, material that we can paint on it. And for GC1, they have this adhesive enhancing primer, which actually what it does is it acts as a self-conditioning bonding agent to the tooth, but then it actually interacts with the cement. And what it does to the cement is that it causes it to go through a self-cure mode. So it has excellent bond strength. So we can see that when we start looking at adding the primer to these, we start seeing almost a doubling of the overall bond to the overall tooth and to the restoration. And we're starting to see the other manufacturers as well, like Reliax and Maxim and Panavia. They're doing a very similar thing as well, is that they're adding their own bonding material to these kits to basically create what we call a universal bonding system. And so that eliminates having multiple boxes of different materials in your office. This dental advisor study shows here of how where we start to add these different types of materials to enamel, dentin, we start to see a significant change between enamel and dentin, as well as we start to see the zirconia, so in the Lysopress, or basically a lithium disilicate. So as you can see, we're going from systems of where they're more challenging to where they're a lot more streamlined and universal, if you will. And that's the goal of the manufacturers, is to make this process easier and less complicated. The other thing we have to think about when it comes to cement characteristics, we have to think about the overall viscosity. If you haven't used a variety of different cements and bonding materials out there, just like your composites that you pick up every day, some of those are a variety of different viscosity. Same thing with radiopacity. This right here is a quick x-ray that I showed on one case that had a piece of cement this is a resin modified glass ionomer, but it's readily easy to pick up in a case like this. So we need it to be radio opaque. We also need it overall color and overall color stability. We need to think about the overall water absorption solubility of the material. We have to think about the handling properties, the overall adhesive strength, and like I said, the biocompatibility. And of course, one thing that we don't really think a whole lot about, and thank goodness we don't have to think about a lot of this, is we have to think about sometimes there are those few patients that have allergies and hypersensitivity to specific components in cements, which there again, some resin cements do have things that patients are sensitive to. So we have to think about that as well. And I will say that resin modified glass ionomers do have resin components in it. So we have to consider those things when it comes to bonding and or cementation of indirect restorations. And like I said earlier, we have to think about the overall ability to manage the overall moisture in the field and in subgingival applications. And of course, like I said, we have to think about, is that material translucent or not? And of course, we have to think about knowing the different materials for the indirect restoration. And not only do we have to know the cement or the bonding material and the bonding protocol, but we have to know the indirect material that we're working with. And of course, as I mentioned earlier today's indirect materials, of course, we still have metal and metal ceramics, but by and far, most of us nowadays in the dental field are using all porcelain restorations that are in the lithium disilicate and zirconia. I would say that this is probably a huge section of indirect materials. And of course, monolithic versus cord. We still have some cord materials where we may have a zirconia restoration core with a pressed material over top of it, depending on the situation. And of course, nowadays, one of the hot things that's out there, and I would say stay tuned when it comes to that, is printables. Printables are coming on strong. There is a plethora of printable materials that are going to be coming out. And of course, each of these materials are going to then require us to do a little bit further research on how we can bond and or cement these materials in place. So stay tuned when it comes to printables. Material conditioning. When it comes to porcelain, we have to think about proper etching. So when it comes to most of our lithium disilicate restorations nowadays, unless you're using a feldspathic restoration, we're going to be etching it much longer with a higher hydrofluoric acid. And of course, there are ceramic primers out there on the market if you don't like to use the hydrofluoric acid. And of course, you have to use less time and a lower concentration with lithium disilicate in order to get an ideal etch of the material. And of course, we do not, I repeat, do not sandblast the inside, especially lithium disilicates, because it can create microfractures. And of course, that can lead to long-term restoration failure. And of course, if we kind of look closely at this lithium disilicate crown here, we can see the frosted pattern on the inside here. This is actually drying after a primer application that I delivered the other day in office. And you can see as this kind of has a frosted appearance in it. And like I said, ultimately, do not sandblast these materials. And of course, if they have a lot of residue from saliva or bleeding or anything that may be going on that gets inside of these, you can simply clean them easily with phosphoric acid that we etch teeth every day with. Clean them really well, scrub the inside, rinse and dry, and if you need to reprime, then you're ready to go. And of course, The next material that we're talking about is the one that's most popular, zirconia. Zirconia is the material of choice nowadays in today's dental world. In other words, it seems to be the most rapidly rising material in use. And of course, the key with it is that you have to sandblast the inside of it with a low pressure for 10 seconds. And we want to hold that at a distance of 10 millimeters. And of course, if we're going to be bonding it, we have to have a primer that has the 10 NDP containing primer in it. That's the secret sauce that helps us bond to zirconia. And so, as I mentioned, zirconia, of course, like I said, it is the hot material nowadays in today's dental world. And of course, like I said, this comes from Marcus Blatz up at UPenn, which he is one of the four founders from zirconia bonding and is an expert in that field. And so his very simple, what they call ABC protocol when it comes to bonding zirconia. So it's a very easy acronym to remember. You want to use air abrasion of the restoration with a 50 micron aluminum oxide at 2 bars or less than 30 PSI. And we then want to apply the monomer primer that has the MDP in it. And most of the ceramic primers that we have nowadays in almost all kits have an MDP in it. And then we add our composite resin cement, and then we deliver the restoration. So that's a simple zirconia bonding protocol for those of you out there that want to bond zirconia or have situations where you may need to bond your zirconia. So the question then comes is, do we bond or do you cement? And do you really have to? That becomes a real question. And of course, we have to follow through a lot of the things that I brought up earlier to help you think through the process. But ultimately, when we start looking at this study that was published in the Journal of Prosthetic Dentistry back in 2019, right in the midst of COVID, this was a beautiful systematic review that they looked at. And I'll highlight what they found is that they reviewed 17 clinical studies. They had 1,280 participants. They had over 2,400 zirconia and lithium disilicate crowns. And when they looked at the ones that were adhesively cemented with zirconia crowns, their survival rate was between 83 and 100%. And when they were conventionally cemented, their overall survival rate was 82 to 100%. And when we look at adhesively cemented lithium disilicate crowns, the overall survival rate was 83.5 to 100. And then, of course, when they were conventionally cemented, it was at 98.5%. And of course, the overall time range for this was anywhere from a little over 2 years to over 10 years. So this is a pretty wide range clinical study and review of several different clinical studies. And based on this information, the overall available evidence is that basically when these restorations have adequate thickness, whether you're using zirconia or lithium disilicate based restorations, they actually exhibit comparable survival rates when we're either bonding or conventionally cementing them. So the key here when it comes to this is, bottom line, research is evolving. So do your research. In other words, you have to stay in the loop. I want to thank you all for being here tonight. That's part of the reason why I wanted to share some of this research, because it is important for you to kind of keep up with us different things. And of course, the last thing we'll talk about is the tooth pre-treatment. Obviously, the tooth has to be properly pre-treated to get a successful outcome for our cements or bonding agents to stick to the tooth. And so resin modified glass ionomer is really easy. You just got to clean the surface mechanically. You can use a pumice and prophy angle if you want. You can use a micro etcher, whatever your choice is, but you just got to simply clean the surface well mechanically. When it comes to these self-etched, self-primed cements and adhesive ones, obviously the surface has to be thoroughly clean. In my practice, a lot of times I'll use a micro etcher with aluminum oxide. And of course, I clean them really well. And of course, the question is whether to etch or not to etch. And of course, a lot of times I will use selective etching, especially if there's some enamel exposed. It all depends on case by case. And of course, there again, we have to make sure that the tissue is managed properly. I'm going to show a couple of technique cards here. It just simply shows, like, this is GC1 that shows their variety of different steps in their card for their bonding protocol, whether you want to use it with the self-etching or using their adhesive resin or adhesive enhancing primer. And of course, this is their other resin cement that shows a wide variety of where you can rinse and dry, use etching, you can use self-etching, you can do selective etching. And so the whole point of me showing these is that the key is, bottom line, follow the manufacturer's instructions for optimum results, because bottom line, these manufacturers have spent a lot of time, effort, and energy into their R&D, and they want to have an ideal outcome. And so that's the reason why they put these together. So let's just simplify things real quick to kind of wrap this up. Ultimately, when it comes to lithium disilicate, if you've got adequate thickness, and you got adequate retention and resistance for them, you can simply get the tooth and the restoration ready, and you can actually just cement it in with resin modified glass ionomer, as long as it's not in an aesthetic zone. But if you've got inadequate thickness, if it's an aesthetic zone, if it has inadequate retention and resistance form, then we're going to prepare that tooth, and we're going to probably go through some type of bonding protocol with a self-etching or an adhesive resin cement. And for zirconia, similar thing. If we've got adequate retention and resistance form, we can simply prepare the tooth and use a cement like a resin modified glass ionomer. Or if you have inadequate thickness, inadequate retention and resistance form, then you prepare the tooth and use a bonding protocol in order to get an adequate outcome for that. So without further ado, I want to thank you all for your time and attention this evening. And I'm going to try to open this up for some questions here. So what I'll do is that kind of read out through these questions as they come in through the Q&A. One person asked if I numb patients during delivery. Many times I do numb patients, especially if I am using an adhesive resin protocol. And so I have found that it's much easier managing the restoration and the bonding protocol if the patient is numb. And so then I don't have to worry about that. Let's see a thank you here. Someone mentioned that they use a different type of cement. See if there's any other questions coming in. Well, I don't think we've got many other questions and answers. At least I'm not seeing any other ones come in. And if so, then I really appreciate everyone coming in and spending a little bit of time this evening with me. And I want to thank again GC America for, okay, somebody did ask about bonding a zirconia. What is your favorite type? I'm not quite sure if it's a particular type of zirconia, if I have a certain type of zirconia that I like. Particular, what I usually use when it comes to that, if I'm using an aesthetic zirconia, it's a katana, which is Curari's aesthetic zirconia if I'm using that. And the other one is a 3M product that they've been around for a long time. So there again, I want to thank you all for your time this evening. And I hope you all came and left with a little something more than what you came in with. And there again, like I said, I want to thank GC America again for sponsoring this evening's Viva Learning webinar. And I hope you all have a great rest of the week. And thanks again.